Great.
Well, thanks.
Thanks, guys. Hey, Dr. Savoie, thanks for joining us.
Absolutely. It's my honor.
Hey, well, I just want to say we were at OSET this week, all of us except, were you there? I didn't see you there, Dr. Savoie. You weren't
No,
at
sir.
OSET, were you? No, okay. And neither was Dre. But the other four of us were there. Yeah, Dre got lost, apparently. Yeah.
Somehow Dre thought Yale was in Chicago.
Yeah. So somehow he didn't make it, but the rest of us were there. And I had multiple people stop me telling me that they love watching this journal club. So I just want to thank everybody. Yeah. Oh, it's great. I just want to thank everybody for watching. We have some people that said they've literally been on every single episode. So that is really, I'm proud of that. That really makes me happy. I hope it does the rest of you guys that do this every week. So we've got a great show today. We've got Dr. Savoie with us. I'll let him introduce himself and tell him about it. Dr. Savoie, just tell everybody if they've lived under a rock the last couple of years and they have no idea who you are. Do you mind just telling us real quick who you are?
So, well, I'm currently the chair of the orthopedic program at Tulane and past president of the American Academy of Orthopedic Surgeons, as well as Shoulder and Elbow Society and the Arthroscopy Association of North America. So pretty busy shoulder and elbow surgeon. We just timing was good. I just walked out of my last case, so
perfect.
It's worked out.
That's perfect. We also have Andre Labe with us. Andre, tell everybody who you are.
Basically, I'm the physical therapist here at Tulane. I'm an instructor with the Department of Orthopaedics, and I work kind of exclusively with Dr. Savoie in multiple areas, from doing director of rehab for Tulane Athletics, also working on special projects with Dr. Savoie in an outreach program. And recently we are launching our motion analysis system in the Raxon clinic here in New Orleans. So similar to him, busy, not as busy as Dr. Savoie, but I've kind of hooked up my my trailer to him. So I'm just going to ride this out. So
there you
go. Hey, Dre, we know it's not as busy as Dr. Savoie because it's a full-time job for him just to keep up with you and keep you doing what you're supposed to do.
Agreed.
Well, if you guys have been on the Journal Club before, you know me, Rob Mansky from Wichita, you know Phil Page, and you know Mike Voigt. So to save time so we can spend more time talking to the Savoie, how about if we skip the introductions of the rest of us? Is that okay with you guys? So Dr. Savoie, we got like all kinds of questions. I've got some questions for you to ask you before we actually get into the journals we're going to discuss. And one of the first questions I want to know is why did you decide to get into orthopedic surgery?
That's a long time ago. I went to med school to do family practice, and two things happened. One, I was at the bowels of Charity Hospital in New Orleans, and as a med student, and I wandered into one of the old amphitheaters, and Don Faust is a hand surgeon here in town, was a resident. He was presenting a case to these guys, and they were just having the best time. Well, those guys were Paul Brand, probably one of the greatest hand surgeons, and worked with leprosy patients for a long period of time, wrote some incredible books, and fine Christian man, and Dan Reardon's famous hand surgeon here in New Orleans, Gene Dabzies, who just passed away, and Bob Chenard, and they were just having the best time looking at this patient. And I went, gosh, whatever they're doing, I just went to find somewhere to study. And I said, whatever they're doing, I want to do it. And then I did. So I said, well, I would do an orthopedic rotation. And on the first rotation, another guy named Dickie Robichaud, who has passed away, it was July 4th weekend, and they admitted about 60 patients over the weekend. He said, here's a list of patients. They're somewhere in this hospital. Go find them, fix whatever's wrong with them, and come back and tell me. And so I had a good time. And so I figured, well, what the hell? I think I'll do this. So and then was fortunate enough to train with some incredible people and kind of gravitated to where I am. So
that's awesome. Awesome story. I heard you, I think it was you said in a meeting, maybe it was this summer, that you were saying that like a large majority of your caseload now is just like almost all revision type cases. Is that correct?
Yes.
So can you tell us a little bit about that?
I'm sorry?
Can you tell us a little bit about that?
Well, it's just fun. You know, I've been around a long time, and so made a lot of mistakes. And so part of the deal is I can look at those mistakes and maybe recover from them because I've made so many of them. And then it's kind of nice. I have some great folks around here, orthopedic surgeons that love to try to fix things. And when it doesn't go well or it doesn't turn out right after a couple of times, then they know I like to do it. I think it's a challenge to try to put it all back together. So it's revision cuff, revision instability, and then revision arthroplasty, both shoulder and elbow. And fortunately, most of them seem to get well. So I feel very lucky.
Oh, you are. Yeah. And that's great that you like that. It's great that you like that difficulty and enjoy working with patients like that. I got all kinds of questions, guys. If you got Phil, do you guys, Mike, you got any questions? So I'm not hogging the show.
I'd throw one out to you, Dr. Savoie,
Hey,
is that I think we talked about this at one of those little fine restaurants you took Dr. Bird and Ash and I to. But can you, as president, when you were president of the academy, that year when you served in that, what did you learn that year as being a leader of the society or the academy, excuse me, and maybe along those lines, what was your greatest challenge that you had to face as a leader?
So the Academy is a terrific organization. We represent everyone. So it's kind of nice. And certainly there's a lot of growth. The amount of problems that people have around the country, but the one great thing is that orthopedic surgeons love taking care of patients. And, no matter where I went, Amy and I together, we visited 46 of the 50 states during the time. It's impressive how well orthopedic surgeons, our physical therapists, our all of us that work to make patients better, that really deep-hearted want to get people better. I mean, it's just an honor to try to serve folks that want to do that kind of thing. I mean, I'm sure other professions have people that want to get their patients better, but ortho, I mean, it's what we do. And that was one of the best things. Leadership, I figured out that orthopedic surgeons in general, everybody says it's like herding cats, and that was 100% true. And one of the best ways to make sure that they don't do what you want is to tell them that they have to do it, because then whatever it is you just told them they had to do, they're going to do the opposite. But it's refreshing to try to help. The biggest challenge is to keep the academy focused on what's important, which is patient care and unity. We all have to work together. There's enough hospitals and insurance companies and government that are threatening how we take care of patients, and that threat is real. I mean, they're all denying care. You guys know that as therapists, you've got to submit things, and every time you submit it, they say no, and you ask for 20 visits, and they give you 10 and tell you it's supposed to be well in 5 visits, and so the challenge is to try to make sure that our folks, not just our orthopedic surgeons, but everybody has the capacity and the permission, so to speak, to take care of people till they get well, and that's critical. So there are a lot of other things that happen that were sort of off base, but playing in our sandbox, that's the biggest thing that I see, is that I've got to protect our ability to get people well. That's what we do.
That's true.
Hey,
Rob, let's jump into it, Rob. I know, because with Dr. Savoie, we chose a couple papers tonight and look at, and I know Dr. Savoie is a pretty humble person, being around him a long time and looking at, but you are truly one of the innovators when it comes to shoulder. And again, I tell people this, I tell my students, you're the guy that all the shoulder surgeons turn to when they don't know what to do. You're the guy that figures it out. And so we chose a couple of things tonight we felt like, and we may dive off a little bit from the papers, but are kind of some of the innovative things that you're involved with and know about. And I thought that sort of sets it up for you, Rob, if you want to jump into it.
Yeah. So if you don't mind, buddy, we'll start with the one about the collagen patch.
Sure.
Did you see the articles by chance?
I did. I saw both of them.
Liam, heck, you wrote them.
Yeah, well, I know he did the one. He did the one, yeah.
So I wrote the one, and I was on the study group for the other one.
Oh, perfect.
Yeah.
So when we start talking about these collagen patches, what is the reason, do you think, that the initial anatomic repairs that you do, what's the reason they fail so often? I mean, why? So we have to you're using these patches now. Well, why do they fail so commonly?
So you don't have to use the patch to get a rotator cuff to heal. So when we looked at our results based on tear size, the anatomy, everything else that's going on, there's a few things that happen and why they fail. Because rotator cuff surgery across the board is pretty successful for the most part. But you'd like to think that We'd love for 100% of rotator cuffs to heal. But when you look at the structure and the vascularity of the rotator cuff, that vascularity, that capacity to heal declines with every decade once you pass 30. So the cuff itself is becoming less elastic. It's losing blood supply. The blood supply comes from the medial bursa. The stem cells for healing come and they form this cartilage type enthesis, for lack of a better term, between the tendon and the bone. So when you start looking at the basic science, you actually have a bad environment for healing. And so then you have to differentiate between a true traumatic rotator cuff, where somebody falls off a tree and they tear their cuff and you fix that. That's a huge vascular environment. The body's creating healing, as opposed to these chronic impingement related enthesiopathic tears that have poor blood supply. So when you try to look at all of that, it just doesn't have the capacity to heal. Then you go in and you fix something that has a poor healing capability. If you don't do anything extra, then that capacity to heal is less. And as we keep studying this, the things that are important are just amazing. Vitamin D levels. Vitamin D is an integral part of tendon turnover and forming elasticity. Vitamin C is an integral part of collagen cross-linking. Then you have muscle atrophy. You need to be on some supplements of some kind. So there's a million things that can happen. Plus, even though biomechanically we can do a good job of fixation, we tended to err more towards biomechanical analysis and things that would work in a cadaver lab, and forgot sort of about the biology where, sure, if you put 6 anchors in, maybe it's rock solid when you put them in, but 6 5-millimeter anchors account for 30 square millimeters of space when you only have 24 millimeters for the tendon to heal the bone. So if it's all plastic, not going to heal. So I think that higher failure rate does happen. And then technically there's some things that we can do. We can do releases to make there less stiffness on the cuff. They can go, yes. Sorry. And so there's a lot of different things that happen, but the overall success rate, if you just take all comers, is still about 70%, same as it was with open, same as it was with mini open. We track ours on ultrasound, and ours is tear size related. So it's a long-winded answer to your question, but our very small tears heal about 98% of the time, and then the medium tears will heal about 95%, the larger ones about 92%, and then the massive ones and revision ones, which is the majority of my practice, hit about 85 to 88%. Now that sounds pretty good, unless you're one of that 12 to 15%, right? So, and if I do, I had some phases where I was doing almost 2,000 rotator cuffs a year. So the percentage of people walking around with pain, not healing, very high. So we're always looking for different things. So I have a couple of patients who are pretty world famous nutritionists, and they will send me stuff to look at, and then biomechanically we keep looking at it, we keep playing in the lab. And one of the things that came about was this Regeniten patch. And when Steve Arnosky, you guys all know Steve, he's the guy that found the blood supply of the meniscus a long time ago, that let us change from doing meniscectomies on everybody to repairing it. I kept telling him over the years, he's a friend, that I needed something to improve vascular supply to the rotator cuff. Well, lo and behold, he's getting ready to retire, and he calls out of the blue and says, "Hey, I'm working with Des Bacher, and I've known Des for a long time. We wrote a few papers together on this patch." And I said, "Well, I'd like to take a look at it." And Les Matthews was involved a little bit, so we sort of got together and tried to figure out what it was doing. Well, it's non-structural collagen, but it stimulates neovascularity. All right, so if we can improve blood supply, then it makes sense to use it on cuffs. Now, the interesting thing is that Des, who was the first guy to put one in, I think I was the third person to put one in, but Des used it for partial tears. So if you look in this country right now, people are using it for partial tears. The people that use it for partial tears are folks that take the cuff down, so they have a partial tear. They cut out the good and the bad parts of it, and then do a full thickness rotator cuff repair. By definition, that means you're going to have the success that you have on that patient with whatever success you have with the full thickness rotator cuff. That's bad. because partial tears, if you leave them in place, will heal about 98% of the time. So my pastas, we do a tension band technique. We don't take it down. I mean, when we have a failure, it's like catastrophic. I stay up for 3 nights trying to figure out what the hell happened because they should have healed, right? I don't know what went wrong, but in general, they pretty much almost always heal. God never lets you get 100% because you can't be perfect, but
That's right.
But they don't. But for my practice, when I'm dealing with these large, massive rotator cuff tears that are less likely to heal, and my success rate is 85%, I need something to do better. So we did a study, which is the paper you wanted to review, and looked at large and massive, mostly revision rotator cuffs. And lo and behold, we found that we got 11% better healing by adding the patch. Everything else was identical. So the only thing that we changed was to put this patch on, and 11% got better. So that's 11 people out of every 100 that I don't have to reoperate on. And the fun thing was following that on ultrasound, because all of these patients got ultrasound every 6 weeks, and then we MRI'd them at a year. And truly amazing, because this is a long time ago, so we've gotten more comfortable with it. But in that group of patients, they did better. They had less pain. The ultrasound showed increased thickness off the rotator cuff. It healed a little faster than just without the patch. So it actually was truly amazing. And then you always have some complications, and as we've done it over the years, some get stiff, some get an inflammatory reaction because it's a xenograft, even though it's highly purified. But in general, the results are good.
How does it actually work? Can you explain what you actually do when you use it? I mean, how you use it?
So we use it in the critical zone of the rotator cuff, which is the most enthesiopathic damage or dysvascular part of the cuff. So we do a repair. And we put everything back. We do trepanation holes in the bone, try to get the stem cells out. We save the medial bursa and sew it into the cuff. When we're all done with all of that, we'll insert the patch. And, the company will tell you it has to go in a certain way. Completely not true. There's no structural advantage to this patch. None. It is highly porous collagen. And it comes with a nice little kit. You can put some staples in. Amy, my wife, is a nurse. And when they were trying to develop the kit, she helped them for free. But she helped them develop the instrumentation for it and we went and did a couple of labs for me. She just said, this is what you need to do. She's very intuitive about how surgery works. So she did a really good job with that. And so then you have these little PLA staples. And if you want to put it to bone, there's some peak staples you can use, but it sits on top of the cuff and it's stapled into place. And initially we thought you needed quite a bit of fixation. Well, it turns out it really adheres very nicely. So it sits on top of the cuff and it stimulates new blood vessel formation. It's amazing to watch on a Doppler because you fix a cuff and you don't put the patch on, and you turn the vascular supply on the Doppler bar. You're looking at the tendon and you see a few red dots kind of coursing in this just basically dead tendon. Mm-hmm. You put the patch on and you turn the Doppler on and you look at the thickness is better. The blood flow, the new vessels coming in, and the little microcirculation is a ton better. So it works by increasing circulation. Within 3 months, the patch turns into whatever tissue it's on.
That was going to be my next question. Yeah, what happens to it?
It actually turns. It's just basically almost like a template for the rotator cuff, the tendon, to get thicker. So it turns into the tendon. So you do an ultrasound at 4 weeks and you can see the patch and you can see the tendon. You do it at 8 weeks and it's sort of hard to tell between the two. You do one at 12 weeks and it's all tendon and no patch. It's very impressive.
And it's just, you said it, you just staple it onto the actual tendon itself. You don't actually anchor it to the bone or anything. So it isn't part of the tendon bone healing. It's just sitting on top of the tendon and incorporates into it.
It sits on top of the tendon, but the tendon is sitting on top of the greater tuberosity. Yeah. So it's covered. And then when you staple it down, you can put a bone staple in. So you can actually attach it to the bone if you want. But this patch is not structural. So if you have a gap between the tendon and the bone, it's not going to cause that to fill in. So it really adheres better to tendon, but it'll create new circulation into that area. So new blood vessel. Now the company would love for me to say that it helps enthesiopathic changes, that you could put it on an intact cuff that's just thinning down and having poor blood supply and would improve it. That don't work. So you can't change. It's not a fountain of youth. You're not going to change the age-related changes. And but it would be nice if it did. We've had some folks that we've done some repairs on, no patch or anything, that have come back and they haven't gotten their strength back overhead. And you look, and the tendon, well, we measure it in a normal 20-year-old is about 8 millimeters thick. And for everybody above 40, we'd like to get them into that 6 range. Well, sometimes that tendon keeps thinning, and they'll come in and go, well, I'm losing my overhead strength. And the tendon's about 3.5 millimeters thick. You go, well, your tendon's not thick enough to tolerate what you're trying to do. And so what are my options? Your options are try PRP into the tendon, see if it'll thicken up. And we've got some evidence for that. A study going on, about 70% will respond. We can put a patch on, it'll be thicker for a while. You follow those, in about 5 years, the tendon's back to normal. So it's temporary thickening, it doesn't last. It's not a permanent fix. Or you can, repair the tendon, you can do transfers, there's different things, but it's really interesting device, and very indebted to Steve Arnosky and Des Bacher over in Sydney for developing this thing and letting us start to use it.
Yeah, that's interesting. That's really interesting. So as far as therapy goes, do we as therapists need to do anything significantly different than we do with the regular repair?
For this, no. This is
same thing.
Really, yeah, this is very interesting because you just track it. So for me, I don't actually start any people going to therapy early for any of my cuffs. I think rotator cuffs like to come apart. And you look at some of the work that George Athwal and some other people have done, George Morrell over in Australia, and really most failures occur in the first 12 weeks. And so when sort of a confluence of basic science research into the tendon healing, the insurance companies starting to deny therapy. I mean, you guys are fantastic, and you probably could get a patient well in 24 visits if they start right after surgery. But it's really hard, I think, to do, especially with mine, because they're so big tears and revisions. So we let them do a little bit of little baby passive motion for the first 6 weeks, and then we get them to therapy. And I've still got my visits left for them to get well. And so from a cuff standpoint, it's really the same stuff you're used to, posture, passive motion, and then building strength as the tendon matures. And the nice thing about when I send referrals is that I tell them exactly how thick the tendon is. So the note will say tendon only 4 millimeters thick, very slow, very careful. Tendon is now 6 millimeters thick, push as hard as you want. So we watch that ultrasound on post-op intervals, and really makes a huge difference in their recovery process, because you're not trying to do too much too soon. You guys are all very intuitive, I think, about what you see and looking at the patient and feeling them, but the patients themselves are not intuitive about their shoulder, and we really need to try to get them there.
Yeah, I like that information you're giving them. That's really nice that you give that information, so you kind of have a gauge of how aggressive or how you need to back off a little bit if it's a little thinner. Yeah. That's excellent idea. Guys, you got any other questions? I still got more, and I can keep going, but
keep rolling, Rob.
I feel like I'm hogging him.
Unfortunately, no? I want to add.
So, okay, you got one, Phil?
Well, what does Andre have? The relationship between what you and Dr. Savoie, when you have these types of surgeries, and what's important about the communication that you're going through? As Dr. Savoie says, he sends that information to you. How important is that to you as the physical therapist, and how do you communicate with Dr. Savoie?
Well, we have a very unique relationship that we work really close, and I kind of know his mindset with certain things. The number one thing I've learned with Dr. Savoie over the years is that, we don't really need to go at a pace that's we don't need to go too fast, because if we accelerate what we're trying to do too early, the failures occur. And our biggest problem especially with referrals that are out, that I come into play sometimes when we have patients that are outside of our network that are seeing other therapists. The number one thing we tell them is, slow down. It's okay. It's going to get there. And the reason that we don't have them start therapy early is normally, in most cases, I'll say this, in the world, a lot of other surgeons may do a surgery and they tend to get tight quick. We don't really see that these patients, adhere down and tighten up quick, and we start losing any type of rotation or capsular mobility early. I'd say the other thing is that more than many other physicians I know of, Dr. Savoie is very aware of what the integral part of the hips are, the integral of the core is, all the things that really are the underlying stabilization of the shoulder that really are things that if we want to start someone early, we can do things, lower extremity work, we can do core work, we can do a lot of other things, also contralateral shoulder work. So, Dr. Savoie doesn't know this, but he did a clavicle fracture just now. The guy just texted me. He just got home and wants to know what he can do. So I texted him 2 hip activity. He's one of those guys. So, but what you do is a lot of times
tell him he can ride a stationary bike. So the cyclist.
So, but I mean, I'm kind of in a blessed position because I've got a guy that I work really closely with. He understands more about what we do in therapy than most. And then we are always, just like you guys, trying to find the next best thing. One thing that we've kind of done we have this piece of equipment called a shoulder pacemaker, which is really helping us with scapular stabilization with our patients early on in the rehab phase. But the take-home message from Dr. Savoie is the techniques that we're seeing now are much more, unique and elegant, and we don't need to be going there and bum rush these people and try and get motion back too quick. In other cases, other joints, other surgeries, yes, motion is very important. And it's, of course, in the shoulder it is, but we don't really see where, I can't tell you the last time I had to really crank on a patient or do something really aggressive with that. But we're also learning that the other parts of the body, so the opposite shoulder has carryover. Doing things there really makes a huge difference. We have a young man right now that Dr. Savoie did a cuff repair on, and UCL repair on, and he was at 95 miles an hour for 3 years with a UCL tear. He's repaired it. We've been doing left shoulder stuff and left arm stuff during this whole protective phase, and it's kept him from tempting fate. And the idea is these people get bored and they want to try and do something. And actually, they're not hurting as much as they should. Unfortunately, Dr. Savoie does too good of a job sometimes, and they start feeling good about things. If we can kind of give them something to do that we also know it gives a baseline of motor control before we start using the arm, the shoulder and the elbow and everything is really line up. That's the last phase. If we do all of our job right, it comes much easier then. So,
yeah.
Good,
One more thing, Rob, real quick, Doc.
Yeah.
The paper was published in 2019, and so that's like 4 years ago. Have things changed? Because I'm sure that the data was taken in like 2018,
Right.
Or
Where
before.
are we 5 years later?
Yeah, so we still use it. That was really a pilot study to see if that thing would work at all. So when we got it approved in this country, the company, Rotation Medical, had 2 studies they wanted to do. One was a partial study. Jeff Abrams, Ted Schlegel, some other guys did that one. Lou McIntyre. And the other one was our limb, which was massive and revision cuffs. And so we had that study, and the things about it was, number one, was it safe? And so we found out it was safe. And we thought it was based on some basic science studies, but we needed to know where the problems were. And then the second thing was, would it change your success rate with the surgery? And so when we wrote the paper, it was a proof of concept that yes, you could add it. It wasn't inferior to cuffs, and actually it did increase it. Now what's happened now, once we did that and we figured out it, number one, it was safe. Number two, it seemed to have a benefit in terms of vascularity. We continued studying it. One study we did was we thought patients, when we put the patch on, had less pain globally at 6 and 12 weeks than if we didn't put the patch on. And we actually did a comparative study, kind of randomized who we picked, and really and truly, it wasn't a statistically significant difference. So people would tell you, well, I have less pain with the patch, but turned out when we actually put our numbers together, didn't make a difference. The second thing that happened is I keep waiting for the next big thing, something that's better than this patch, which if you look at new inventions, usually 3 to 5 years, somebody starts coming out with something a little bit better. And the couple of things that have come out have either not had the basic science with it or some other things. So I am eagerly anticipating that this should be sunset pretty soon.
Yeah.
Something better, because it's been too long.
Yeah.
And the last thing that has happened is that the use of it has been pretty widespread, but still some of the insurance companies will deny it. And I'll do it peer-to-peer or something and start talking to them. And I'll go, they'll say, well, there's no evidence. And I'll say, I wrote a paper on this.
Yeah, there is.
Well, yeah, but, and I'm like, no.
Let me get it for you. Yeah, let me get the evidence for you. I know it's there. Yeah.
So they
Hey,
laugh.
Doc, we have a question on someone submitted here on the question and answer. They ask, Peter Galt asked, how do you go about educating patients about the vitamin D and C levels for improved healing around surgery? For example, how much to take and the time frame to supplement before or after surgery. And so how do you discuss that with your patients?
Great question. So many of them, we do a vitamin D level when they come in. Or I'll ask them, do you know what your vitamin D level is? They know. So, well, vitamin D is an integral part of tendon turnover. When you start talking to folks, you'll get people in. So, I'm here for my left shoulder, but I hurt my Achilles, last year, and I did this. I got a little tennis elbow, that kind of thing. You go, what's your nutritional status? Well, I don't know.
Yeah.
So it's not something that comes.
I think it's good. Yeah.
Yeah. So sometimes we just draw the vitamin D level. I'm in a different position because most of my folks have had surgery before, and I also have two world famous patients who are world famous nutritionists, and can't say their names because they're both patients, but they email me each about once a month with something they think will help patients heal better. And
that's awesome. That's cool.
So it's really good. And then when they email me, I got to go research it.
Of course.
Because they have a different perspective sometimes as fitness folks and nutritionist folks. So about 1 in 10 have enough evidence that you could really say, yes, this will make a difference. And so we use a substance right now. We were on something called Juven HMB for a bit. We had our patients taking that with some amino acids that helps tendon healing. So now we're on a different one called MEND, MEND. But what we do is we talk to the patients and say, do you know your nutritional levels? And I'll say, the surgery is an insult to your body. It's like being run over by a truck. And we need to make sure that every part of you is in tip-top shape. So since most of my folks have had surgery before that didn't work, they're willing to grasp at any straw available. And then we have a handout. We have a list of things that we have a general wound healing supplement, which can be Juven or MEND. We have the vitamin D. We recommend 5,000 international units a day. We have it in writing. The vitamin C, if they have any kind of neuropathy, we had vitamin B complex. There's some other things, BioCell, collagen peptides, different things that we'll add in depending on what they look like nutritionally. If their serum albumin is low, then we'll add in a bit more protein or different things. But most people are actually amazingly receptive when you start talking to them that surgery is an insult. We need to maximize your healing ability. We want you to start this at least a week ahead of time, because if you're deficient, you're not going to heal well. And then the other thing we have is we did another study where we looked at their ultrasounds. We put half of the folks, every other person that came in, we put them on supplements, and every other one we didn't. And then we looked at it, and the tendon was about 1 millimeter thicker at 6 weeks if you were taking it than if you weren't taking it. So it's pretty impressive the data we have. So
that's really good.
Yeah, nice. Well, it's just interesting. It's fun to look at it and try to figure out if there's another, area that
another way to tweak things just a little bit to make it better.
Just a little bit,
It's all you need is a little bit. If you're already doing pretty good, you just need a little bit. Yeah.
Yep.
I love it.
Rob, one addendum to what Dr. Savoie said. With the work that he's been doing and we've been doing with our patients with that, we actually implemented that with our football team. So we have started doing supplements daily with them, vitamin D, B complex, C. What I'll tell you is this, and we can speak to it later, but our soft tissue injuries this year are a fraction of what they were a year and a half ago. And so I think we're 1 year into making these supplements available, and the players so every morning when they walk in for breakfast check, they've got a list of supplements that they have to take.
Yeah.
90% of the players do, and there's about 10% that we have offset because we've done blood testing. But it's been kind of interesting that is so prevalent with every patient that you have, no matter what the diagnosis, no matter what the injury. And from a preventative standpoint, I mean, right now we have of course, we collect data on all of our players. We're collecting that comparatively with some other stuff we've done. This has been something that's been a big game changer. So it's been interesting to look at.
It's got to help. It's got to help. Hey, Dr. Savoie, you work with a lot of therapists, right? I mean, I'm sure you see patients and you send people all across the United States. People come to see you from everywhere. So you deal with a lot of therapists. What if you had to say what are some of the top characteristics that you think, when you think of like the really good PTs that you like to work with and that do a really good job, what are some of the top several characteristics you see consistently in those therapists?
So it's really, I mean, people are always interested in patients getting better. And what I really like to see, and it sounds funny because I'm very, very restrictive about how much leeway I give, but I like to have people who are creative who will email me back or call me or text me and go, hey, Mr. Smith is doing this. I think this would help. What do you think? And the answer is usually, and I'll email back and go, what about, because I still remember pretty much all my patients. And I said, well, no, we can't do that right now, or yes, we can. And when you change things, if people are interested in basic science and all the things, and they're kind of looking at the healing, that's very helpful. The other thing, and Andre alluded to this a little bit, I'm a huge believer in hip, core, scapular strength. And so, when people come back and I ask them, are they really making sure your shoulder blade's back? I really like that. And people that are attentive to the patients. What I really don't like is if one of my patients goes in and they just do a bunch of exercise machines, stretch a little bit and slap an ice pack on and go home. That's sort of that, not the kind of thing that we're interested in, not the kind of care we're trying to provide. But, I have been so blessed that the therapists I have worked with from the time I was a little, resident with Wayne Jimenez and Max Thomas down in Jackson to the guys up at ORV in Virginia and the folks over in South Carolina, everybody that I've seen has just been so fantastic and really interested. And, it's just been fun to learn. And I like to listen. I like to get an email. Not everybody texts me at 5 a.m. like Andre does, but he knows I'm awake and he knows I'll answer. So, which is kind of funny. It's not, but in general, a lot of my therapists will email, which is great, and just go, hey, we're thinking about this. And then they're really interested in the patient. They really have the patient's best interest in mind. They're trying to figure out what do I know about where they are? And is it safe? Is it not safe? Can we push a little bit? And that's where the ultrasound and all these things help so much. Because it used to be, I just tried to feel the shoulder and figure out what was happening. And now I get direct imaging. Patients like it. And I can say, no, they were 3.5 millimeters thick. We're not doing a thing right now. Or, gosh, the last time they were in was 5.5. Push hard. Let's see how they do.
Yeah. All right. You guys ready to go to the next paper?
Yeah, it's an extension of this, Rob. Let's do it.
Yeah. Okay. So our next paper is in-space implant compared with partial repair of the treatment for the treatment of full thickness massive cuff tears. So now we're moving to the spacers, and we saw there was a lot of discussion about this at the meeting last week at OSET. A couple doctors talking about using it. It sounds really interesting. I mean, I thought it was really interesting, and they made it sound like it's really works really well. What do you think of the in-space implants?
So there's a couple of things. It's going to be very interesting. So the in-space is going to work for specific indications, and if you're very rigid about your indications, then I think it can really help. Can
you elaborate on that? What you mean?
I will. So okay. The original implant was designed for isolated supraspinatus tears with intact anterior and posterior force couples that had superior migration. That's a pretty rare patient. So to have the subscap and the infraspinatus be totally normal and only a supraspinatus tear that allows some superior migration, that's an unusual situation. So the concept is that the pain was coming from the greater tuberosity rubbing on the acromion, and you wanted to restore those force couples so that the patient can function better. No different than a partial repair, no different than a supracapsular reconstruction, no different than any of those things that rebalance the shoulder. I mean, theoretically, you could go to therapy, and if you could bring the head down and have intact anterior and posterior force couples, you would achieve exactly the same outcome. So that's what it's designed for. Now, in every time it's been available in any country, started in Israel was the guy that designed it, and then it went to Slovenia for the first few studies. The indications get extrapolated. You know, in orthopedics, if you have a sledgehammer, everything looks like a really good nail to hit. So, so if you don't restore your force couples with the spacer, it's not going to work. If you do a decompression and you detach all of your coracoacromial arch, that spacer is going to pop right out that area, so it's not going to work. So the idea behind it, if you can do it correctly, and Joe and Nick and the guys that designed it, they had very rigid indications about what it could and couldn't do. That was a very well-controlled study, and those patients did very well. So then the question is, where does it fit in the panacea, you know, and all the things that we do in the shoulder? So we have an ongoing study right now where we're actually repairing the rotator cuff, we're putting a patch on, and then we're putting the spacer on top. It's horrendously expensive. Because the spacer is not cheap, it's very expensive. The patch is not cheap, it's expensive. Plus you're fixing the cuff. And I'm an anchor minimalist, so I don't use a lot of anchors. But so I think that, like anything, it's not a miracle. It's going to get overused. But I do think there are specific indications, but you have to have your force couples intact for it to work.
Yeah.
One of the things that I liked about the article, first of all, that was a really well done article in terms of the design, the stats. And what I liked about it was the follow-up and the fact that they relied on physical therapy, the rehab part of it. Like you said, Doc, is restoring that force couple. They talked a lot about how the deltoid had to be re-educated and things like that. So it's a really good article about how the interaction is the surgeon. The surgery is as important sometimes as the rehab in this.
Oh, and Phil, I got to tell you, in this group, the rehab is more important than the surgery. There's no question that these people, well, all you're trying to do is put the head in a better place temporarily so that they can rehab their shoulder and get better. Because if they don't rehab the shoulder, that surgery's not going to work worth a flip. There's some things we do that the patient's going to get well pretty much no matter what. This is not one of them. This is an entire re-education program for all 27 muscles that act around the shoulder. Every one of them has to be readjusted. It is not an easy rehab by any stretch of the imagination.
Yeah, when they talked about it this weekend, they really talked about it almost just like a temporary, because it doesn't stay there forever, right? It reabsorbs and it just kind of stays in there. They talk like it stays in there as that spacer to limit the superior translation, allow the shoulder to kind of calm down. So that you can actually work the muscles like you're describing, Dr. Savoie. You can start using all those muscles with less pain, and then by the time it degrades or absorbs or whatever, you've got a better functioning shoulder. I mean, is that really kind of it? That's kind
of it. All it's done is push the head down and let the cuff kind of move up. So when we do it, I always release the inferior capsule so that I'm not as tight. When you talk to Joe or Nick, they'll tell you, some of these people, you put that spacer in, their shoulder's so tight they're in a lot of pain. Well, that's because the inferior capsule has contractures. If you release that capsule at surgery, you don't have that. The head can move down better. So the idea is the head moves down, the front of the cuff comes up, the back of the cuff comes up. It stays there long enough for them to readjust and now become a force that keeps the head down. And that, 6 months, if the cuff doesn't heal and the force couples don't reestablish, the head goes right back up.
Yeah.
It's quite impressive because you watch it, looks good, and all of a sudden,
may I have your attention, please?
I'm paying attention.
Yeah.
Was
that you, Dr. Savoie?
Yeah. Sorry.
That's
For
okay.
information session regarding the transition.
Sorry.
Please join us to get information about transition dates,
Right.
PTO, benefits, and anything else you may be wondering
Hey,
about.
Rob. I'm glad
course,
you were paying
refreshments
attention during that
will be
lecture. I
served.
thought you were sleeping when Joe was talking about
No,
it.
I was awake. Yeah. No, I was
Sorry
awake. I
about
liked it. No.
Rod, one little minor addition to that is that if you think about this technique, you're introducing a foreign substance within the joint and above the joint.
Yeah.
And one of the things that we found is that it actually takes longer, a little bit more
Good
work
evening.
to get
May I have your attention, please?
scapular stabilization
LCMC
come back,
representative will
even
be
the
in the
cuff to come
Louisville
back.
room for information session.
Because you've
regarding
got now
transition.
this foreign body within it. So it's almost like when you do PRP and the muscle shuts down because you've added cells to an area. Just keep that in mind. So,
Yeah.
and this lady that's on the intercom.
Yeah, sorry about that.
That's what happens. You do it in the OR. It's like working with children and animals. You never know what's going to happen.
You don't know
Not a
what's
live
going to
show.
happen. That's right. It's live. It's
This
live.
is real. He's really
Yeah.
in surgery, guys.
He really is there.
All right, Dr. Savoie, we got another question from Caleb Strasberg. Building off the rotator cuff thickness values you mentioned, would it be feasible to use ultrasound diagnostic? This is a long question, okay, so bear with me. Would it be feasible to use ultrasound diagnostic imaging available in the clinic to guide clinical decision-making? For example, exercise parameters such as load intensity volume, as well as healing progression. Could this also be used to determine the need for referral early, possibly like referral for the patch?
Absolutely. So we do ultrasound on every rotator cuff patient that we operate on. They get an ultrasound every time they come in. So it's pretty easy to guide that way. One of my partners is a physical medicine rehabilitation doctor. He is superb, does a lot of EDS work. He ultrasounds them and tries to determine what they're capable of doing and when they need to come in. So we share a lot of patients, especially the hyperlaxity patients. And he will ultrasound them and send them over and go, I think this cuff is really thin. I think it's an at-risk patient. What do you think? And then so they'll come over, I'll look at them, I'll do my exam and everything. We'll ultrasound them and go, this is, because what we found over time is that if your rotator cuff is 3 millimeters or less, you're going to have an operation. It's just a question of when. It's not thick enough to tolerate anything. You don't have overhead function. It's going to turn bad. It's too thin. If it's 4, you can probably do your waist level stuff, and we always try to rehab and we try to isolate it down and see what happens. But some of them don't have that capacity to recover. The tendon doesn't get thicker. So then that's the promise of PRP, of stem cells, of nutritional supplementation. So on those patients, you start throwing everything at them that you can to try to get it to thicken. And if it doesn't, then adding a patch to that is a good idea. I've talked about that with some of my post-ops where they come in and they just won't get thicker. We'll talk to them about PRP, about going in and adding a patch, and there's some that say, absolutely, I can't do what I want to do. I need a better tendon for my muscle to work. And so it's very impressive to see. I think it's a great idea. And when you start looking at it and categorizing them, this patient is this thick, and then you follow them along, and all of a sudden they go, my shoulder's terrible. You do an MRI, it's torn now. It's like, and ultrasound is so easy, it's painless, it's less expensive than an MRI. And sometimes it's fun if the machine's just there. We'll MRI people for free all the time. Ultrasound people for free all the time, just to see.
I'm sure you don't know this, Dr. Savoie, but the majority of us on here are kind of turning into ultrasound nerds. We've each got our own ultrasounds, and so we play with them all the time. And so it's really exciting, fun, and more therapists are starting to use them more. I'm assuming you do it out like toward when you're talking about the thickness. Are you talking out kind of toward the footprint of the greater tuberosity?
So we measure it at the same spot every time. It's just off the articular edge, anterior supraspinatus cable, just posterior to the biceps. So that tendon right there in a young person is going to be 8 millimeters thick, and most older adults, anybody past 40, is going to be about 6. And then when it starts to thin from there, it's very interesting that it correlates with function. 6 millimeter thick cable, you can do pretty much anything you want. When it goes down to 5, you start getting a little fatigue overhead. 4.5 is where they can get the arm up over their head, but it just drifts down on them. And they'll tell you this, and you put an ultrasound on, you go, it's only 3.5 millimeters thick. You're not doing anything overhead right now.
You shouldn't be, no doubt.
I got to do a shameless plug for the journal, because we do have an article coming out in October about supraspinatus ultrasonography. So
great.
You can check that out. So, Doc, you're doing the modified craft position like this, and then putting it up on the oblique
right there. Yep.
Okay, perfect. That's exactly what we talk about.
Yep. So, there you go.
Listening to this, check out the October 1st issue, which will be out Sunday. Mike and Rob and I were both authors, or all authors, about an article on imaging the supraspinatus tendon. That's
Oh, great.
Yeah, we have kind of a series we've been doing the last probably six, 7 issues.
That's awesome.
Yeah. Thank you. That is just kind of a shameless plug, though, Phil.
That's okay. That's good knowledge. It's a good thing to share. That's perfect.
Yeah. So, Doc, this the paper said. So, is it really this fast? The paper said it takes like 3.8 minutes to do the spacer. I mean, it's like
It's
on
fastest
average.
thing. Yeah. Technically, it's not much of anything. You run into trouble if you don't put it in the right spot, and it's because it is a spacer. If you put it too lateral, it'll come out lateral on the acromion. It's really hard to put it too medial, but anything is possible. And then the other thing is that if you have to make sure your coracoacromial arch is intact, because you don't want it to squirt out through any defect. But I mean, basically, you put it in the right spot, you fill it up, you back out a little bit, and you flip the knob to cut it off, and it's done.
Nice.
It's
nice.
not hard.
It's very fast. Yeah, very
Yeah.
fast, expedient. We have someone there. This is always interesting when we get a question on the question and answer thing from an anonymous attendee. I'm never quite sure how serious to take these, but this is from an anonymous attendee. It says, "Can you elaborate on the biologic implant tuberoplasty?"
Okay, so that's a very interesting thing. So when SCRs started coming out, supracapsular reconstruction, originally Miata did fasciolata from the leg. In this country, they went to dermal patches, and that's what came out. People putting these dermal patches on. Well, they stretched. They weren't really as thick. They were 3 millimeters, 4 millimeters thick. So the short answer is, although a lot of people, and like anything, it has its indications, it was too broadly indicated. One of the things that was interesting, though, is that when it healed to the greater tuberosity, so you had your tuberosity, you smoothed it down, you put this dermal patch on it, and it's supposed to be from the glenoid to the humerus and hold the head down, just like the spacer, except it took much longer, cost a lot of money. There's an extra $10,000 or $12,000 per case when you did this, and a lot of OR time as well. Well, a subset of those patients, as they followed them up, the graft healed to the greater tuberosity, came apart, so it didn't really hold the head down, but the patients remained better. So even though it didn't do what it was supposed to do, it didn't keep the head down, it didn't do any of the stuff, some of the cuff may have healed, but because the greater tuberosity was covered, that they did better. So this dates all the way back to John Fenlon, an older orthopedic surgeon from Philadelphia, had a thing called a tuberoplasty, and he would smooth it down instead, and in cuff tear arthropathies before reverse shoulders, so that when they moved their arm, the surfaces matched, so it was very smooth, and they would have less pain. Fast forward to now, the dermal patch is healing to the greater tuberosity. The patients don't hit bone on bone, so that the greater tuberosity is not hitting on the bone of the acromion, and they move back and forth. So there's a few people doing studies on that right now with some very good preliminary results. That you forget the other part of the SCR, just put it on there, do your tuberoplasty, put the dermis on, they have less pain and they do better. Now it's the same thing as the spacer. You have to have biomechanical force couples front and back, but it's the same issue. And there are a few people doing this with very good results in cuffs that are not fixable.
That's cool.
Yeah.
So what do you? We have like about 5 minutes left.
Oh goodness.
Yeah, this goes quick, man. It's like you start the hour and then like literally it seems like 10 minutes and it's already up. What kind of things get you excited about the future of surgery, shoulder surgery? I mean, what kind of new things are coming up that you just think, wow, I'm glad I'm still doing this, and this is going to be exciting the next couple of years?
I think there's so much fun stuff. So from an arthroplasty standpoint, all of the virtual reality, artificial intelligence, robotics, all these things I think are really exciting. I know a lot of people are scared of it, but gosh almighty, when you can look at a 3D image and rotate it around and play with it on, just in the air and correlate that to a patient, I think that's fabulous. So that's one thing. The second thing is the future of biologics in the shoulder, I think, are tremendous. I mean, we're just scratching the surface nutritionally with PRP, but I think there is a world of good in in the whole stem cell research, PRP research, all the things. And we have a fair amount of that going on here, but that holds the promise to get people better, or to be able to supplement what we're doing surgically to get better. You know, so that's all exciting. And the way people learn is so different. You know, I actually have a talk on where I think the future is going in shoulder surgery. And I think it's going to do nothing but get better. The fact that you can do 3D imaging and we can build in catastrophic things that happen and how we train folks. And then some of the haptics that are available that are coming down the pipe, where I could sit right here, put a pair of gloves and a VR headset on and be in somebody else's operating room, and they would actually feel my hands moving their hands.
Yeah,
I think it's the most amazing things that are happening. You know, the future is very bright for innovation, for shoulder surgery, for taking care of patients. And, you know, I mean, you can fuss about insurance, about everything else, but I think it's always about getting people better. And technology and all the things that are happening, I think will hold a world of promise for us to do a better job.
I agree 100%. And I mean, I think we're all blessed to be able to do what we do and to help people like we do. I mean, not only you and the surgeons, but us as therapists to get to help people every day to try to get better and help you do what you're doing and make it better. I just feel like we're extremely lucky. And I agree with you that it's just going to keep getting better.
Yeah.
You guys have any closing remarks? Other than Dr. Savoie, I mean, I know you are like extremely busy. And so we appreciate you so much for coming and sharing your time with us. It's just unbelievable to be able to sit here and talk to you and learn from you and be able to ask you these questions. So I really appreciate it. If we could ever have you back on again, I'd love to get you back on again sometime in the future. This has been just fantastic.
Well, it's completely my honor. I always learn from you guys, so I appreciate it. It's fun to be a part of it.
Yeah, we really appreciate it, buddy. It's been fantastic.
Thanks.
My closing comment will just be to say that I don't think that you've been just lucky to find all these PTs that are so good at communicating. I think it's the fact that you actually respect us and how we work together as a team. And that's been my experience with Dr. Bird and my experience in spending time with you. So we appreciate how much you value us and work together with us as a team. So many thanks.
My pleasure. Again.
Andre, for just being you, Andre. Thank you.
Hey, Dre, I wanted to know, did you start that healing nutritional supplement thing after the Ole Miss game?
No, actually, it was after the Nichols game. We got our ass beat up more with Nichols than Ole Miss.
Okay.
I was just about to say, Andre didn't drop one curse word at all.
No, he was really good.
We got a streak of one going.
Yeah.
It's Mike's fault. It's always Mike's fault. He's just the quiet bad guy.
Well, thanks everyone for being on. We'll get this recording posted. It'll be very valuable to go back and watch again. Thank you, Dr. Savoie, for taking some of your valuable time, and we'll see everyone again next month.
Great.
Thanks,
Thanks,
everybody.
guys.
Appreciate it.
Thank you.
Thanks.
Bye-bye.